Yes, hello. I would like to welcome everyone to the PartSource HTM Leadership Series. Today's presentation is the first of our 7-week series that will run weekly through November 12th. Today's session, The Right to Repair, Understanding the Challenges and Taking Back Control, is presented by Nathan Proctor and Ilir Kullolli and is hosted by Guy Mansuto. Before we begin, I would like to review a few housekeeping items. First, you have a control panel at the bottom of your Zoom control screen. You can minimize and expand this panel. Second, you can submit questions using the question portion of the control panel. We will answer questions at the end of the presentation. If your question was not answered, we will respond to you individually after the event. All registrants will receive a link to the recording after the webinar. The information will be sent to the email address with which you registered for this webinar. And now, please allow me to introduce Guy Mansuto. Guy Mansuto joined PartSource in October 2017 as Senior Vice President and Chief Marketing Officer. With 25 years in the healthcare industry, Mr. Mansuto brings expertise in healthcare technology solutions for provider, payer, and employer markets. In this capacity, Guy leads efforts to help accelerate growth and facilitates the development of medical device supply chain solutions and service models designed to increase innovation around utilization and uptime. Now, I'll hand it over to you, Guy.
Great, thank you, Jen, and thanks for everyone for joining us on the call today. At PartSource, we believe in partnerships, and with a mission to help drive collaboration across providers, manufacturers, suppliers, service partners, across the healthcare and HCM community, we really believe this is a fundamental mission for us as a company. The goal of this leadership series is to help connect you, other HCM and clinical engineering leaders, to important topics that are helping shape the future of our community, the future of HCM, and future clinical engineering. And one of those most pressing issues is the right to repair. Today, presenting on this topic, we have both Nathan Proctor and Ilir Kullolli. Nathan Proctor leads the U.S. Public Interest Research Group Right to Repair campaign, working to pass legislation to allow consumers to fix their own equipment and empower competition in a fair market. Joining Nathan is presenting today is Ilir Kullolli. Ilir is an international recognized speaker and advocate for clinical engineering, and Ilir is currently the Director of Clinical Engineering, Biomedical Engineering at Stanford Children's Health, and is currently the President of the American College of Clinical Engineering. We're so pleased to have these leaders today presenting this opening topic on our leadership series. And without further delay, I'd like to pass it over to Nathan to help continue the conversation.
Thank you so much, Guy. So yes, I am Nathan Proctor, the National Campaign Director for U.S. PRIG's Right to Repair campaign. And I'm aware that, the right to repair has become a really important topic in the HTM industry. But it's been a really important topic to me for a little bit longer than that. And instead of maybe me explaining your industry to you, since you know it probably better than I do, I thought I could give you some context for right to repair is really all about by talking about what it looks like to restrict repair, in industries across, the spectrum of the economy. And just to give you a sense of how we engage with those industries and how that's similar and how we've moved forward with medical device right to repair. But first, I just want to show a little bit about what the US PRIG is and what the Public Interest Network is, which is our parent organization. We are a state-based advocacy organization with affiliates all over the country. This is just a little map of some of our places where we have active groups. And in a lot of these places, we're also doing advocacy around right to repair at the state level. But first, I wanted to introduce this time by kind of teaching you maybe a little bit about repairing tractors, since I don't think that that's typically covered in the work that you do every day.
We're gonna hook my laptop up to this combine and try to get codes out of it, I guess. I would say what I'm doing is hacking.
Farms today use a tremendous amount of technology.
DeerMates claims that you only really have the license to use their software. And for someone to say they own the software pretty much takes away the whole viability of the entire tractor or piece of equipment.
The only person that can repair those tractors to a great extent is the dealership.
I mean, look at the size of this machine. If I had to haul this thing 100 miles every time something went wrong with it, it'd cost a fortune. I mean, just to get it on a truck is $1,000, and by the time you get it hauled somewhere and get it hauled back, you're $2,000 into fixing something maybe relatively minor.
What we've had developed is essentially a monopoly on repair. One of the things I've been told some guys are doing to deal with these issues is there's pirated software out there from Eastern Europe that guys are utilizing to try to get around this, to be able to work on their tractors themselves.
I believe the software I got's a hacked version of John Deere's system. When it comes to tractors, I mean, I farm, so out of necessity, they break down and I have to repair them in one way or another, and it's a lot cheaper to do it myself than it is to haul it into a repair shop or a dealer to have it fixed. We got lots of, I mean, everywhere on a combine there's a sensor here and a sensor there, and every single little part of it has a electrical sensor in it. A couple of years ago we were doing custom anhydrous as fertilizer on cornfields, and you have a real small window to be able to get this done in the year, and the tractor broke down. So I had to find this software to be able to repair my tractor and make my customer happy and make a living. There's a whole selection of the machines based on serial numbers and what they are, and you got to pick the one out that's the right serial number for this machine. And then you'll be able to come over here. Once you're able to get into this, you know, I can go in and I can do a diagnostic on it, and it'll start checking all the codes and looking for what I have wrong. And then I can go up here and I can look at them and see what the problem is. And
All right, so yeah, so that might be familiar in concept to what some of you might experience, but you know, this is how, you know, repair works on these devices, right? A software tool is required to install or calibrate spare parts, including parts which, you know, pretty frequently wear out. And so you have a sense of what we were looking at in that video, the interior of a tractor. There's a screenshot here of John Deere's Service Advisor software, which is the tool that you need in order to calibrate or install or diagnose problems with that piece of equipment. Now, you can only get that software legally, right? You know, besides whatever is done to get it off of, you know, Ukrainian hackers, if you're a John Deere dealer. And this means that, and then also the tractor occasionally will trigger some, if it has some problem and it decides that the equipment needs service, it'll put the whole machine into limp mode, which you can't we can't take the machine out of it unless you plug in, you know, you have one of these special dongles, which is in the bottom right, you plug in with the Service Advisor software and you clear the codes. So an increasing percentage of spare parts and all these other things are kind of locked into software, and the access to those things is restricted to the dealer. Now, and since 2015, there's been a concerted effort to fix this problem. And our proposed solution to fix tractor repair has been to require that the original equipment manufacturer provide access to replacement parts tools, the schematic or repair manuals, the diagnostic software, and the ability to update firmware on fair and reasonable terms. And in response, you know, John Deere and the dealers associations and the other people who lobby against these reforms would say, listen, if you fix your own tractor, it's so automated it could, you know, the combine could just veer out of the farmland and just start mowing down people, which is actually a thing that lobbyists have said to actual legislators and media. people will soup up their tractors to make them, go faster, and they'll be dangerous, and or they'll, basically farmers are latent criminals and they all just want to cheat on their emission standards, and all of that will kind of, dilute our brand. And there's no current problem. The dealers are doing a perfect job. No one's ever had a problem. And then of course, all these, this software is a trade secret. And I would say, like, this, if you've been in this right to repair space, you recognize that everything you've just seen is pretty familiar. Then in fact, when we put forward medical right to repair, the trade associations, I'm sure who are represented on this webinar, basically argued that this is a solution in search of a problem. There's never been a hospital which had an urgent need to fix a piece of medical equipment and lacked access to parts or service instructions. They say that while third-party servicers play a crucial role, the fact is that they operate in the regulatory Wild West, which I'm sure some of you will appreciate, knowing how much regulation is in this field. And that, the proponents of the, crazy people like me, we're demanding that unregulated third-party servicers be given unlimited access to service manuals and other proprietary OEM information. So I wanted to switch over to cell phones here so you can kind of see another reflection of this. So this is a article from our campaign in Oregon, and Ref. Jeff Barker, a Democrat from Portland, said he doesn't support the current version of our bill because he hopes that backers can tailor a bill that doesn't go after the super secret information that industries have. So he's talking about information like this. Top secret schematic that you can find on Google that tells you how to, which pin aligns to what in a standard, docking thing on a phone. So, I mean, this information is basic service information that's provided to tens of thousands of service technicians in an authorized network, but is restricted to the owner of the product. And then also phone makers will go and lobby to tell lawmakers that there's a huge safety risk if people can fix cell phones. And increasingly we're seeing things like this. These are screenshots of a cell phone which replaced an Apple screen with another Apple screen. They didn't change it's not an aftermarket screen. It's just an Apple screen. But now, without the calibration software that Apple stores use, you get a set of pop-up messages, and you get reduced. You lose features on the phone unless you're fixing the phone within the universe of the manufacturer's control. These problems are inconvenient for consumers. They're inconvenient and expensive for somebody like a farmer who's trying to do his business. But, these are like world-affecting problems. We dispose of 46,000 cell phones a day. We have an absurd relationship with technology, and it's kind of built on the assumption of disposability, which is kind of a new invention. That this consumer behavior has really changed. We've made a dramatic shift in how people treat the stuff that they own, and then how companies are allowed to treat product owners. And I think right to repair is about recognizing and restoring some balance to that system. There was a much better way of doing things where we had a competitive, dynamic, distributed ecosystem of repair, which was more efficient, which gave product owners more options and better price points. And this obviously impacts operations for medical equipment owners. And so I want to talk a little bit about what we've done so far. And over the years, we've worked to include medical device right to repair in some of our state work. But that work really kind of went to a different level over the course of the last 8 months because of the pandemic. I mean, probably early in the pandemic, we started hearing stories, and we started hearing from these repair technician networks that we're part of, that People were getting stockpile ventilators, from the national stockpiles, and they were unable to get the parts and service information they need. They couldn't get the PM kits for the ventilators. So, that kind of kicked off our, our investigation and mobilization. The first thing we did was we collected 45,000 petition signatures. We joined up with a bunch of other groups, including some statewide elected official, like with a project led by the treasurer of the state of Pennsylvania, Joe Torcella. And as a result, we actually were able to free up some of the service information that people were having a hard time getting for ventilators. But of course, the problems with medical device repair restrictions are bigger than that. The next thing that happened was, one of the leaders in the Right to Repair kind of campaign, this group called iFixit, created a new catalog of online service information. They posted, if you haven't seen it, you should go check out ifixit.com. And that's kind of done in concert with our requests that it'd be a lot easier to find this service information. And we also have done some research, and we found our research basically supported the idea that we need new rules and protections to make sure that hospitals have enough options, necessary to safely and quickly fix medical equipment. And as kind of one result of that is that Senator Ryan Wyden and Representative Yvette Clarke introduced a bill to basically to provide more access to what hospitals and ISOs need to fix medical equipment for the duration of the pandemic. And, we have been told, and there's been some coverage of, that there has been a lot more cooperation from the manufacturers during this time. Things have improved. And that to us, that's a really good sign. And we know that this can be the ecosystem we operate in. But of course, we're also asking, how long will this cooperation last? And how can we restore this market and the system to a little bit more order? I wanted to quickly touch on some of our findings because we did a survey of 222 biomeds, and then I'll kind of wrap up my part here. We found that basically of the 222 medical device repair professionals that we surveyed, 30.4% reported to have equipment that they could not use because there were restrictions on parts, service information, or access codes. 92% claimed that they had been denied service information for their critical equipment. And even over the course of the pandemic, nearly half reported that they've been denied access to the critical repair information, parts, or service keys, basically during the pandemic. So our goal really is to, create a system in which there's fair competition for repair services, where product owners should have their rights honored by the manufacturers, where we comply with the NFPA 99 standards that require hospitals to have service information, and then we just have a more cooperative environment between the manufacturers, the healthcare delivery organizations, and the independent service organizations that provide to better care at a lower cost. And Ilir will talk more about this, but of course we're not interested in replacing OEM service, just like we're not interested in replacing all the John Deere dealerships. They will still be a critical part of that ecosystem, but by limiting options, you create dangerous situations for people like farmers. So a couple things you could help. One, you could whip out your phone and you can scan that QR code and you can sign our letter calling for in support of Congress reducing restrictions to medical device repair information. You can work to get your organization to support Senator Wyden's bill. I can be contacted here or on Twitter. And I'm sure we'll have more time to take questions at the end, but I wanted to pass it over to Ilir.
Thank you, Nathan. And thank you, Guy and PartSource for allowing us to do this presentation today. I hope you can see the presentation. So again, my name is Ilir Kullolli. I'm Director of Clinical Technology Biomedical Engineering at Stanford Children's Health. and also president of American College of Clinical Engineering. Just a little bit of information about the American College of Clinical Engineering. It is the only professional organization in the U.S. representing only the interests of clinical engineering professionals. We were founded in 1990. We have over 1,500 members in U.S. and Canada, and over 25,000 collaborating members worldwide. And again, ACCU was founded for, in order to do at least these four things. And I've highlighted some of the things that apply to the right to repair. So again, we're founded to establish a standard of competence and to promote excellence in clinical engineering practice, to promote safe and effective application of science and technology in patient care, define the body of knowledge on which the profession is based, and again, to represent the professional interests of clinical engineers. And a little bit about where I work at Stanford Children's Health. Just wanted to give you a quick overview. We are in the Bay Area, San Francisco Bay Area. We have over 20,000 medical devices that we oversee, and we have over 20, actually more than 30 integrated systems right now, such as ECG management system, cardiology packs, EEG, EMG, patient monitoring, a lot of things that a lot of clinical engineers do out there. Provide 24/7 on-site support, and we oversee the cybersecurity program for medical equipment, and we make sure that we are aligned with the overall cybersecurity program for Stanford Children's Health. And since we're at Stanford, we support many research projects. And a quick overview about the department and our workload overall. As you can see, we do about 1,300 monthly work orders, where 300 are incidents, 800 PM, and about 200 or so are repairs. So, the right to repair is quite important to us with the amount of workload that we have here. Again, like everybody else, completely regulated by Joint Commission, CMS, all of our medical equipment, our FDA medical equipment. Try to address all the calls within 15 minutes. And the other thing, again, we have over 20,000 medical devices. About 6,000 of these devices are networked, and about 40% of that send data to our Epic EMR. And I'll touch upon that later and why this is important in the right to repair. So today I'll just give a little bit a brief history on the right to repair and touch upon the concerns of different groups and how they can be addressed. And a little bit about the history. I want to actually thank Bin-Sang Wang here, which a lot of people know. He did help me quite a bit with putting down the history on the right to repair, because this is work that has started long before I became a clinical engineer. And, I wanted to make sure that I captured everything that I could in this presentation. Again, the right to repair in 2012, as you can see in Massachusetts, they passed the Automotive Right to Repair Act initiated by the Aftermarket Automobile Industry Association. And then again, same year, a lot of states considered or passed similar acts. In 2013, Digital Right to Repair Coalition was created and was renamed later the Repair Association. In 2014, again, the AAIA and other auto repair organizations signed an MOU with the Alliance of Automobile Manufacturers and Associations of Global Automakers, where OEMs will provide to owners and independent repair facilities the diagnostic and repair info, repair, technical updates, and diagnostic repair tools, which is, diagnostic car code readers, which, a lot of us can obtain these days. In 2014, Unlocking Consumer Choice and Wireless Competition Act allowed cell phone owners to unlock the cell phone and transfer it to another carrier. Yay. That was very important for a lot of us. And again, a little bit more history here. In 2014, the first digital right to repair bill filed in South Dakota, and a bunch of other bills were filed in other states, as you can see, through 2018. And then in 2018, the U.S. Copyright Office Library of Congress issued the rule exempting provision of the Digital Millennium Copyright Act that prohibits circumvention of technological measures that control access to copyrighted works. Exemption for computer programs that control motorized land vehicles, including farm equipment, for purposes of diagnosis, repair, and modification of the vehicle. And again, in 2019, bills were filed in West Virginia, Oregon, Indiana, North Dakota, and Georgia. And all this, happened outside of the medical world, if you will, the medical devices. And back in 2017, 2018, there was a lot of work that was going on around medical device right to repair. So the FDA organized a workshop back then where, a lot of people participated. We had people participating from the American College of Clinical Engineers, a lot of hospital representation, ISO representation, manufacturer representation. And the FDA, after the workshop, they had a report, which was a report, again, on the quality, safety, and effectiveness of servicing of medical devices. And the report, which was part of a year-long study, concluded that the objective evidence indicates that many OEMs and third-party entities provide high-quality, safe, and effective servicing of medical devices, and the continued availability of third-party entities to service and repair medical devices is critical to functioning of the U.S. healthcare system. Again, this was what FDA reported, and this didn't come out from the hospital or from ISOs or from anybody else. And in addition to that, the FDA advised that the collaborating communities should be created in order to come up with some solutions to this problem. So, and then, again, the collaborating communities were created to work out mutually agreeable solutions. However, after, I believe they met a few times, but the MITA, Medical Imaging Technology Alliance, and AdvaMed, and some manufacturers withdrew from the collaborating communities, and effectively rendering any decision that these communities made ineffective. And what are some of the manufacturers' concerns? What are they bringing up? I don't work for a manufacturer now, but I've seen a lot of articles that are being published. I've seen a lot of things that come up, after the bill was introduced by Senator Wyden. The objections that came out, and some of the objections were, what Nathan mentioned earlier, the need to protect proprietary information. However, the right to repair, having access to service manuals, doesn't do anything to that. There are copyrights, there are patents, which again, these things, they provide no effects of maintenance. They say that there's a lack of regulation of medical device maintenance. But as I mentioned earlier, a hospital is a 100% regulated environment. We are regulated by CMS, the Joint Commission, many state regulatory agencies, which oversee maintenance of different equipment. So again, we are a very highly regulated environment. And again, the FDA found that, we provide high quality service that is critical. And again, some of the other reasons, which I'll be talking a little bit more in detail, are allowing unfettered access to software raises serious cybersecurity risks. And they also mentioned that risks to the safety of patients and clinical professionals, there are risks to the safety of patients and clinical professionals due to improper maintenance. Well, let's take a look at the serious cybersecurity risks. I think everybody would agree that medical devices are already a big cybersecurity risk for all healthcare organizations out there. And why is that? Because, over 90% of our devices have an outdated software. There's a good reason for that. We do keep devices for 8, 10, 15 years in a hospital. We don't replace them every 2 or 3 years like you would replace computers. So, as a result of that, a lot of manufacturers cannot provide updated software. So, we are already putting an organization at risk if we rely on the software that's on the devices. So each of our healthcare organizations are doing, we're doing our own cybersecurity risk management, independent of what a manufacturer has. We are putting devices on separate networks to address all the serious cybersecurity risks. We are deploying microsegmentations, putting devices on different devices on different networks. So in case a device gets affected by a virus, it doesn't affect all the other devices on the network. We are deploying our own network monitoring and limiting tools, and we are providing access control solutions on our own. Again, if you look at the serious cybersecurity risks, I think they are already there, no matter what the manufacturer does. And each hospital is doing the best that they can in order to apply these solutions. And again, whether a manufacturer updates or doesn't update the software, or whether they repair or they don't repair software, we still have to do all this. So really, having a manufacturer say that there are serious cybersecurity risks to allowing us access to these devices, it's really not true at this point. And let's take a look at the risk to safety of patients and clinical professionals due to improper maintenance. Well, let's give this, we have a very good example right now, the COVID-19, where OEM staff was not able to be on site due to health concerns, travel restrictions, and had to be home, like all of us. I mean, there were some times where I didn't want to go to the hospital because, I didn't know what to expect there. But, I had to show up, as did all my staff. So, however, the OEM staff, they didn't have to show up. All they did is call us and tell us that they cannot make it. There are travel restrictions, which we understand. And they had health concerns, which, again, we understand. However, they asked us to address all the repairs, recalls, and PMs in the hospital, things that we were not trained to do because these these manufacturers not only didn't train us, they were not allowed to train us to address these repairs and recalls. So we had two very serious recalls during the time of COVID, where we didn't have access to these devices to perform those recalls. So what the manufacturer did is they sent us a USB stick, and they told us, hey, you're certified to address these recalls right now. So please go ahead and do them. So, we got certified on the spot. And this was only done because they couldn't show up. But it also shows how easy this work is. It's not something that our BMATs, our CBATs in the hospital cannot do. I mean, these guys, they are, they're geniuses at coming up with solutions. And really, having a USB stick that has the software in it, and they can, for them to upload the software, it's really, it's not rocket science. So again, during the COVID-19, we had delays in addressing issues, because of this, because they weren't showing up on site. Delays in receiving parts. Now there was a supply chain issue, but also in some cases when, in some cases where they certified us on the spot, we called the parts department in the same hospital, in the same supplier, and they wouldn't provide us parts because we were not supposed to receive parts because we didn't have the training, but they hadn't received a message from their own team telling them that, hey, these guys are okay to receive parts. So again, there was a delay in receiving parts because of that. And again, there was a big delay in performing crucial preventive maintenance due to people not showing up and because of COVID. And another reason why, I advocate for hospital staff to do the repairs and maintenance of equipment is because we have a much better look at the big picture. So as we know, our hospital, the rooms and the operating rooms are getting more and more connected every day. I mean, in this picture, you see an infant warmer, a patient monitor, capnography monitor, you see some pumps around, blood pressure monitor. So all these devices are getting more and more connected. So it's the same thing in operating room. You have an anesthesia machine here, you have a microscope. So, the anesthesia machine is connected to a patient monitor, sending data to EMR. The microscope, again, is connected to the digital OR system. And you may have a C-arm, an MRI somewhere there in the back. So all of these devices are getting more and more connected. So just performing a repair on a device doesn't mean that you know what's going on with all the devices around it. So we've had, I don't know how many cases where, I mean, I can pull the data, I should pull the data, where, an OEM field service engineer came over, fixed the device, however, broke something else, broke the connection of this device to other things. The engineer left. The next day, we go there and we couldn't see images from from different C-arms. In addition to that, now somebody else, in a lot of cases, some of these doctors, they didn't have to be on site to look at these images. Now they have to come on site and look at the modality instead of being able to see the images remotely. So again, a lot of issues with the workflow. I think that technicians in the hospital, they have a much better view of the big picture. They know what device is connected to what. And once they're done repairing one of the things, they can also make sure the device works in the ecosystem of the hospital. And we don't just have connected rooms, we also have connected hospitals. So everything is getting more and more connected. And it's important to keep that big picture in mind as we're doing these repairs and preventive maintenance. So, as I mentioned, the in-house techs and engineers, we have a much better view of the bigger picture. Devices are interconnected, workflows are changing and complex, and we are aware of those. Availability of equipment, again, is erratic. Like when a manufacturer, when an OEM field service engineer shows up, they show up, let's say, from 12 o'clock to 5 p.m. in the afternoon. However, the device may not be available at that time. So, we end up getting charged in many cases, we end up getting charged for something that we couldn't control. So we are, it'll be a lot cheaper if we got the training ourselves. Again, we do provide better, faster, cost-effective service, and patient and staff safety and trust, that's always, with the in-house techs. And again, our incentive is towards patients and staff. We don't need to generate income for a company. Our staff is held accountable for PMs and repairs. We have incentives towards reducing downtimes, reducing device-related errors and risks. These are all things that are measured at the hospital level, at the leadership level. And we also, again, must meet all the CMS, TJC, Joint Commission, state regulation on device PM and availability. And again, we are the de facto experts when there are issues with devices. Whether something is OEM supported or not, the first person they call is Biomed. So we need to know how to address, at least how to do a first call on these devices. So because of that, the third-party services also, because of the issues with the right to repair, they formed the Alliance for Quality Medical Device Servicing. Again, they formed this in 2018 as a response to the FDA report, and in helping with collaborating communities. And they put together a team in order to, in order to address the right to repair issues. And again, the Alliance members are, you can see the big names here: Trimedics, Sodexo. And they're doing a great job in order to support the right to repair. In addition to that, ACC and a bunch of groups, we got together and we helped, again with Nathan and the U.S. PRIG, sponsoring, helping Senator Wyden sponsoring a bill on the right to repair. We also made sure that they hear from us as since we are the advocates for the profession. ACC and the ACC board felt strong that we need to support the right to repair. And, we're very proud and very excited of the bill that was drafted by Senator Wyden. And hopefully we'll see that bill pass the Senate floor soon. And just a quick overview of the right to repair bills throughout the country. You can see, all these states in the right have some right to repair bill introduced, and the ones that are grayed out do not have any right to repair. So if you are from one of those states, I would say try to get involved as much as you can in order to pass a right to repair bill, because it's really important. If we are not speaking up for the right to repair, we are really speaking against it, because the status quo is speaking against the right to repair bill. So, if you are for the profession of clinical engineering, for the profession of biomeds out there, in order to help, to help the profession, I think you need to speak up in order to in order to defend the right to repair. Again, some of the things that that happened with COVID-19, which they were there, they just were brought up to the surface because of COVID-19, is that we got caught unprepared. We turned to untested and unapproved solutions because we wanted to, we wanted to take care of equipment. We wanted to make sure our patients were being taken care of. Again, we fixed equipment without any training, fell behind on PMs. And I know that, Nathan mentioned that manufacturers, they started cooperating a lot more after the pandemic, and that's true. However, since we were not trained before the pandemic, it took a while for us to get some training on some of these devices. And again, that is because we were not prepared. For the next pandemic and emergency, we need to be trained before the emergency hits. We need to have the service manuals and parts handy. We need to have access to the devices and systems so that we can repair them and repair them on the spot. And again, there are costs and patient safety. Service contracts with manufacturers are expensive. I mean, we all know that. They are a lot more expensive than if we were to service things in-house, or even if you were to hire a third party to service them. But also, manufacturers are each other's biggest customer. And I wanted to highlight this because a lot of these manufacturers that do not support the right to repair, they actually do provide service for each other. So, let's say you have a device from Philips, a GE person will be able to service that because they have agreements with each other, and they provide parts at a cheaper price for each other. And I think that's something that we need to look at, because it's it's going to make it a lot harder for us to defend the right to repair. However, to me, it's also a little bit hypocritical of manufacturers not to support the right to repair when they are not actually servicing their own equipment. They're also servicing other manufacturers' equipment. So, and the other thing, rural hospitals out there, I don't think a lot of people talk enough about those, but, there's a lot of systems out there that, are very hard to get to. And we need to be able to give those people the tool to service the equipment when they need to service the equipment, and not, a month later or a week later or even a day later. It's too late. And again, in order to address this, we need a path to being able to service equipment, get the training by the manufacturers on fair terms, service manuals, service codes, parts availability. And again, we need to negotiate service as part of the capital purchase. That's the only time we may have a little bit of leverage to, when it comes to the right to repair and the service. We want to be able to negotiate parts, training, and, everything else I mentioned above, service manuals, service codes, and all of that. So that's the only time where we may be able to get some, something out of the manufacturers. And again, we do need access to the software keys, diagnostic and repair information that manufacturers currently provide to its own distributors and service staff. We need to be able to collect data generated by the device operating and self-diagnostic software because this can potentially improve patient safety and maintenance. We need to be able to run network-based diagnostic and cybersecurity scanning software. I mean, right now, medical devices, you cannot scan them because they'll fail. You're not allowed to scan a medical device for viruses. Well, we want to be able to do that. If the manufacturers want to keep the environment safe, they need to allow us to be able to do this. And also, we need to be able to perform backup of data and software in our own storage systems and not, somewhere in the cloud, in the manufacturer's cloud. And what can you do? Again, if this is something that I've been doing, so I'm hoping that, a lot of you will be doing this. It's work with your hospital leadership, supply chain, to provide data on the benefits of the right to repair. Have them support you and speak up for you. Have them support this at the AHA, American Hospital Association, or state hospital associations. And again, work with local and national clinical engineering and HTM organizations. Advocate the right to repair with them. Have them participate and sponsor this initiative. Again, as I mentioned earlier, if the organization that's claiming to support you and support your profession is not speaking up for you and for your profession and for the right to repair, then, they're speaking against it. The status quo is not acceptable. Status quo is not supporting the right to repair. So I'm begging you to do that with your organizations. Do that, local, especially locally. I think that's very, very important. And again, thank you for participating. And I think we have some time for questions.
Great. Thank you, Ilir. Nathan, that was fantastic. It's a very important topic, and I appreciate you taking the time to go through it. We'll start opening up for Q&A. You'll see a Q&A section at the bottom of your control panel. Feel free to submit your questions. But while we're waiting for that, I just had a couple questions for both the panelists, and then I'll turn it over to Jennifer Buck, who will guide us through the questions from the audience. So I think it was Winston Churchill who said, "Never let a good crisis go to waste." It sounds like, Nathan, that the pandemic has kind of put more rigor into the process, more rigor into accelerating legislation. Do you feel, out of all the different industries you work with, do you feel healthcare, because of its intensity on patient outcomes, because of the sheer number of medical devices, because of its focus on quality, is really the best place to start for right to repair from what you've seen? How does healthcare fit in the landscape from your perspective?
I mean, that's a good question. I mean, how does it fit? I mean, one, I think that it's different than some of the other fields because the universe of technicians working on these things is, and the environment in which they're doing it is so heavily regulated, and there's so much, so much in that FDA report in 2018 that really looked into, all these error reports. It's, we haven't done that for, all these other industries. And there's conclusive evidence that there's not a quality justification for restricting access to repair. So I think that that's really important. The other thing is that I think is really important about healthcare is I think we kind of, we have a sense of how critical it is that our healthcare system be made more resilient. And that, it wasn't that like, I objected to the way you kind of put that, don't waste a crisis, because, I wasn't planning on working on this. I mean, literally the field came to us and started telling us we desperately need some help. They were worried about their patients because of the way that when the pandemic started and the OEMs couldn't come in, but they also couldn't get access to what they needed. I mean, that was a really bad situation. And that was, and we just happened to be some people in a place where we had some idea about how to address situations like that.
Yeah. Well, I appreciate the insight, and I meant that in a good way, that there's always a solution. There's always some some compromisers a way to make this work, and it sounds like healthcare is a great place to start. When you look at the legislation from Senator Ron Wyden from Oregon that you helped introduce, Critical Medical Infrastructure Right to Repair Act, and all the other states, it seems like they coalesce around a few different topics. One is addressing copyright liability, addressing patent infringement, addressing contract terms and warranties. Are they all about the same in the states that haven't yet tackled this? Or are there a lot of variance between the legislation from your perspective?
Well, you left out one of the key important planks of the Wyden bill, which is that it requires manufacturers to provide on fair and reasonable terms access to information and tools used to diagnose, service, maintain, or repair equipment. So, and that is essentially the core of the state approach. I would say that, you know, typically when you're dealing with these things, there are two kind of categories. One is the intellectual property category, which states really do not have jurisdiction to really go into. And then there's the content, like the actual materials. And that's always been the focus of the work that we've done in the states. Like, can we get the actual materials that the manufacturer has produced that allow you to operate this product safely, which they will not provide or will provide only under certain conditions. And so that to me is the most immediate thing that we need to get to. And then I think that there are certain things in the long view that Congress has to think about and has been thinking about in terms of the intersection of intellectual property rights and copyright with how to protect manufacturers' ability to, you know, make products and have patents and have strong copyright, but then also without undermining the rights of the owners of those products.
Yeah, no, that's super helpful. Well, I appreciate the insight. And Ilir, I just have one question for you, and then we'll turn it over to the Q&A. You know, having been in healthcare for a while, you know, one of the things that PartSource is really focused on is helping get our customers access to clinical resources and to help them improve clinical availability and uptime of medical equipment. And when I think about the report that US PIRG came up with around that 48.8% of biomeds surveyed had denied access to critical information, parts and service keys for medical equipment, it makes me pause and makes me think through, okay, are we doing enough to help equip the clinical engineers, the biomed engineers, technicians at the front line? You know, as you're thinking about right to repair and you're thinking about how leading HTM departments can actually prepare for this and preempt, you know, challenges in the future, we're finding, you know, some of our customers are actively pursuing, you know, ISO certification, quality certification. Would you recommend other strategies that clinical engineering directors should consider to help get their team equipped with the right resources for their work? And what would those be?
Yeah, thank you, Guy. I think you hit it right on the head. A lot of places are trying to do something, you know, in order to prepare for what may happen. The issue that I see with, let's say, an ISO certification, you know, I know a quality management system has been suggested to help with this, to help with the right to repair. The only concern I have there is that we may be creating more work for ourselves, and it's not necessarily more work for, you know, for Sodexo or for Trimedics. I think it may end up being a lot more work for your rural hospitals, where you have 1 or 2 or 3 biomeds. You know, I mean, talking to them about the quality management system and having them implement the quality management system, it's, you know, it's worse than, it's probably worse than having, you know, the manufacturer service the equipment for them. So I think, you know, we need to be careful when we suggest things, you know, things like that, and making sure that we don't create more work for our technicians in the field. And frankly, you know, I mean, we are a very, very regulated environment. There is, you know, like everything that we do is measured. It's not, we cannot mess up. I mean, the moment we mess up, we have to report that. manufacturers don't have the exact, the same requirements. We have those requirements. If something happens in the hospital, an adverse event, we have to report that. So, our technicians, our engineers are very aware of that fact. So, we keep improving. We have other things, other reporting tools within the hospital to make sure that we keep improving. And I think, that's something the Joint Commission is also looking right now. They're looking at improvement opportunities rather than just, your usual PMs and your usual repairs. They're looking at how you are continuously improving in the hospital. And I think that's a great idea. Developing a quality management system may work for a lot of larger hospitals and, larger organizations, may not be the best solution for, smaller hospitals out there. And, if that was to happen, I think it might be a disservice to a lot of smaller hospitals.
I understand that the resource load and issue that might put on smaller community hospitals for sure.
I want to add one thing to that too, because it's funny that the opposition to our bill has called our bill like a solution in search of a problem, when I can easily document the problem that we're trying to solve. But the FDA investigated whether or not there was a problem and found that there wasn't, but they're still advocating for this solution. I find that somewhat ironic.
Yeah. Well, I do as well. I think it's a lot of this is bring folks together and trying to get the resolution. Again, thank you guys for your help, really making a difference here, moving the conversation forward. Let me switch over to Q&A. For folks who are on the webcast, feel free to submit your questions using the Q&A control. In the meantime, we have a number of questions here, so I'll flip through a few of them, and then we'll get to as many as we can before the end. So the first one, it sounds like this is a director of clinical engineering who is asking if leadership is okay with the ability to move forward with the right to repair, what can they do within their purview, within their control, to help raise the issue? What should they do in order to help identify some of the solutions and reasons why that I think, Nathan, you presented? What suggestions would you provide to them to kind of raise the issue?
I can address that. I'll find it hard, it will be hard to find people unless they do not understand the right to repair. It'll be hard to find hospital leaders that will not support it. Yeah. And again, I'm sure there will be some out there. And again, that's going to be because they probably don't know enough about it. I think in that case, you just have to work with the data. A lot of the hospital leaders, they will look at the data and understand the data better than they will understand me or you. So if you can provide information on them, how it can be cheaper, how it can be faster, and how it can be better, for them to support the right to repair, I think they'll believe it. And it doesn't, it's not something that starts today. It's something that, that has started a couple of years ago. That's how you build your reputation within the hospital. And then, once the leaders, they trust you, they know that you and your team do a great job, then you can bring these things, in front of them. They need to be able to trust you before they can start supporting you.
Yeah, that's fair. I appreciate that. The second question is a little more in terms of, well, let me read it. While some of the manufacturers are stepping up and helping assist in-house teams, and a lot of times we're seeing hybrid models where OEMs and manufacturers help support the in-house HTM departments. Can you or would you expect any of the large OEMs to join in that movement? And what's your sense in terms of timing? Do you think this would be a 2021 breakthrough, or do you think it might be even sooner than next year?
That's just anybody's guess, frankly. I don't know if OEMs will be compelled. I think I'm sure they have much better data than we do in terms of, where they make more money, whether it is in defending, whether it is in supporting the right to repair or not supporting it. If they support the right to repair, means that they can service each other's equipment, so they'll make some money there, like everybody else. However, if they don't support that and nobody can repair their equipment, they might be able to make more money that way, which probably, is true. So I would say that they'll look at that information and probably make a decision based on the information that they have there.
Yeah, okay. And I could share experience from other industries where you have very similar to the medical equipment and device industry, where you have a couple really dominant players who have, it's pretty easy to understand, that this is their approach to the market, and this is how they're going to run things. And then there's a bunch of other companies who they aren't trying to run. Might offer some service, but that's not primarily their a competitive advantage. That it's not really what they're trying to do. And so I know that there's other electronics manufacturers who are not, for example, nearly as opposed to right to repair as Apple and Microsoft and Samsung, but it just doesn't really help them to stick their neck out in a lot of ways. So we have private conversations with folks, and they recognize that, they kind of agree with us. They think we're right, but it's been taking a long time to go from, those companies are ready to comply with the law as soon as it's passed to being public about supporting it.
Yeah. Well, we'll do one more question and then we'll wrap up. We got a lot of questions, so we'll try to get back to those questions directly, and certainly Nathan and Ilir will be available through communication directly as well. Just one of the questions that seemed interesting, I guess, Nathan, this goes to you. Are you seeing other strides being taken in other industries, not healthcare, that can help, that we can help apply those learnings to healthcare to help move the dialogue further and faster?
Yeah, I mean, my impression is that we've made improvements in the healthcare, industry over the last 6 months, that we've put pressure on manufacturers, and we provided some, feedback essentially, and that we've gotten some response that, companies have decided to be more cooperative, and that's been beneficial. Even in some cases where they've come back to renegotiate contracts to make them a little bit easier to work with. And I think that that's terrific. And I see that happening in other industries as well. But I recognize that only happens because we're kind of forcing that conversation to move forward with a little bit of regulatory risk. So I think it's critical, if we want that conversation to continue, that there needs to continue to be, looming accountability. And so that's why I think and the more support we have, the more likely that we'll resolve this. Because right now, I don't think that the playing field is even when it comes to, how the regulations and how the market is situated.
Yeah. Well, I think we're at time, but again, thank you guys. This has been fantastic. It really helps me pause and think through strategies that we can take within our organizations or locally within our states to help move the dialogue forward. So let me turn it over to Jennifer Buck, and she'll help wrap it up.
Thank you, Guy. Thank you, Ilir and Nathan, and all of our attendees for your time today. As a reminder, everyone will receive a follow-up email that includes a link to the recording of today's presentation within 2 to 3 business days via email. And please be sure to join us next Thursday for the next installment of the HTM Leadership Series with the title HTM Staffing Optimization, Achieving the Highest ROI for Your Organization, presented by Jeremy Cook, Senior Director of HTM at Methodist Le Bonheur Healthcare. This time, the webcast is ended. Thank you for attending and have a great day.
Thank you, everyone.
All right, thank you.